Have you ever noticed that feeling maybe when you're really stressed out or perhaps having a panic attack? That lightheadedness, maybe a bit of tingling?
Oh, yeah, around the mouth or maybe in your fingers.
Exactly. Or even just during really intense exercise, your breathing just sort of takes over, right? Speeds up.
Oh,
It's your body
yes.
reacting.
Well, we've all been there, I think. And it's actually a fascinating look at how fast our bodies can respond to things. So today, we're doing a deep dive into something called respiratory alkalosis. Now, it sounds a bit technical, I know,
It does, yeah.
but it's actually one of these really fundamental ways our body keeps everything in balance,
Yeah.
that delicate internal environment.
It's a key part of our physiology.
Think of it like
Yep.
a chemical dance happening inside you, mostly unseen. So our mission today is to go through the sources we've gathered and really pull out the key pieces of information.
Right.
We want to understand what respiratory alkalosis actually is, why it might happen, what it does to your body, some surprising effects there, and how doctors figure it out and treat it. Yeah, how it's diagnosed.
Right. Hopefully by the end, you'll feel pretty well informed and maybe have a couple of those aha moments about how amazing your body is.
And I think understanding this specific condition,
Mm-hmm.
it really does open a window onto the bigger picture. The complex ways our bodies work constantly to maintain uh, equilibrium, homeostasis.
It really shows how interconnected everything is. Okay, so let's unpack the basics. Respiratory alkalosis. What are we actually talking about here?
So at its heart, it's when the partial pressure of carbon dioxide, that's the PCO2 in your arterial blood, goes down.
Okay, PCO2 drops.
Right. And because CO2 acts like a mild acid in the blood, when it drops, your blood pH goes up. It becomes more alkaline. We call that alkalemia.
So less acid means more alkaline. Makes sense.
Exactly. And why does the CO2 drop? It's usually because your lungs are working overtime. They're breathing out CO2 faster than your body's cells are producing it through metabolism.
That rapid, sometimes deep breathing we call hyperventilation.
Precisely. Hyperventilation is the direct cause of the drop in PCO2.
So it's all about that balance, like you said, the balance between CO2 production and CO2 removal by the lungs.
That's it. And it's amazing how quickly breathing can change that balance. CO2 is transported in the blood in a few ways, mostly as bicarbonate, but the key measurement in blood tests is that dissolved PCO2. It directly reflects your ventilation. Breathe faster, PCO2 goes down, pH goes up.
Okay, so PCO2 is obviously super important here. What's considered the normal range? What are we looking for on a test?
Good question. Normally in arterial blood, the PCO2 should be somewhere between, say, 35 and 42 millimeters of mercury, millimHg.
35 to 42. Got it.
So if we see that arterial PCO2 dip below 35 millimilliHg, that's a big red flag for respiratory alkalosis.
And you mentioned arterial blood specifically.
Yeah, venous blood usually has a slightly higher PCO2, maybe 43 to 49 millimilliHg, because it's carrying CO2 back from the tissues. But the arterial blood gas, the ABG, gives us the best window into what the lungs are doing right now.
Okay. It's still kind of amazing to me how just breathing faster can cause such widespread effects. It's not just about the lungs, is it?
Not at all. That's where it gets really interesting, like you said. The effects ripple outwards.
So what kind of things are we talking about?
Well, take the brain. When PCO2 gets low, we call that hypoxemia, it actually causes the blood vessels in your brain to constrict.
Oh, really? Less blood flow.
Exactly. Less blood flow. And that can lead directly to neurological symptoms. Things like feeling lightheaded, dizzy, maybe confused, having trouble concentrating. In really severe sudden cases, it could even trigger seizures.
Oh. Okay, so that explains the lightheadedness. What
Yes.
else?
Then you got electrolytes. Alkalosis, the higher pH, actually causes shifts. It can lower the active ionized calcium levels in your blood and also potassium levels.
Ah, and that causes...
That's often the reason for those tingling sensations, the paresthesias you mentioned earlier, especially around the mouth, hands, feet. It can also lead to muscle cramps or even spasms like carpal pedal spasm, where your hands or feet might involuntarily contract.
Okay, that tingling makes more sense now, tied to calcium.
Right.
What about the heart?
Yeah, the heart can be affected too. Severe alkalemia can cause veins to constrict venoconstriction, and it can make the heart more susceptible to arrhythmias, irregular heartbeats. Some people might feel palpitations or even chest tightness.
So brain, electrolytes, heart, anything else?
Well, the kidneys jump into action too, but more slowly. They're the compensators.
Right, trying to fix the pH imbalance.
Exactly. They sense the high pH, the alkalosis, and they start to generate more acid, basically hold on to more hydrogen ions, and they excrete more bicarbonate, the alkaline buffer, in the urine to try and bring the pH back down towards normal. They also adjust chloride levels to keep the electrical charges balanced.
It's fascinating. So many of those symptoms, the tingling, dizziness, muscle cramps, you wouldn't immediately think, oh, it's because I'm breathing too fast.
No, absolutely not.
Yeah.
People often worry about neurological problems or heart issues first. It can be quite counterintuitive.
What's maybe the most unexpected symptom link you've seen?
Perhaps how profound the neurological effects can be. Seeing someone genuinely confused or, in rare cases, having a seizure just from hyperventilating during, say, a severe panic attack.
Yeah.
It really hammers home how critical that CO2 balance is for normal brain function.
Yeah, that's powerful. Okay, so given all these potential effects, it makes you wonder, why does hyperventilation happen in the first place? What triggers it?
The causes are really diverse, very broad range.
Can we group them somehow?
Yeah, we can think about them in categories. First, you have this sort of acute physiological triggers, things like intense exercise, running a race, or fever, high body temperature, even just strong emotions, pain, anxiety, fear, excitement. Panic attacks are a classic example here.
Okay, so everyday stuff, potentially.
Right. Then a really powerful stimulus is hypoxemia, low oxygen in the blood.
Ah, okay.
Yeah.
Like at high altitude.
Exactly. High altitude's a perfect example. Or lung problems that impair oxygen exchange, like pneumonia, a pulmonary embolism, a blood clot in the lung, severe asthma attacks, interstitial lung disease, even severe anemia, where you don't have enough red blood cells to carry oxygen.
Makes sense. The body tries to get more oxygen by breathing faster, but blows off too much CO2 in the process.
Precisely. Then you have central nervous system disorders, things affecting the brain's breathing control center, head injuries, strokes, brain tumors, infections like meningitis or encephalitis. And interestingly, a salicylate overdose, aspirin poisoning, directly stimulates that respiratory center.
Aspirin, wow. Okay, what else?
There are other medical conditions. Sepsis is a big one. The body's inflammatory response and increased metabolism can drive breathing. Liver failure can cause it too through something called hepatic encephalopathy. Early stages of fluid in the lungs, pulmonary edema, or lung scarring, pulmonary fibrosis.
It seems like a lot of serious conditions can cause it.
They can. And then there are iatrogenic causes, meaning caused by medical treatment.
Like in the hospital.
Yeah, most commonly being on a mechanical ventilator set too high, breathing too fast or too deeply for the patient. Or sometimes even during CPR, if manual ventilation is too vigorous.
Okay. Any others?
Just briefly, sometimes it can be a compensatory response. If your body has another problem making the blood too acidic like metabolic acidosis, the lungs might hyperventilate to blow off CO2 and try to compensate for that primary acid problem.
Right, the body trying to balance things out again. Okay, that's a huge range of potential causes. So how do doctors sort through all that? How do they actually diagnose respiratory alkalosis?
The absolute key test, the gold standard, is an arterial blood gas analysis.
An ABG.
Okay, the blood test we mentioned earlier.
Right. We draw blood from an artery, usually the wrist, and the machine analyzes the gases. For respiratory alkalosis, we're looking for two main things. A high pH above the normal range, so typically over 7.45, and critically, a low PCO2 below that 35 mmol Hg threshold.
High pH, low PCO2.
Got it. Now, the bicarbonate level, the HCO3, helps us figure out if it's acute or chronic.
Okay, how does that work? Well, if the hyperventilation just started, like in a panic attack that's acute, the kidneys haven't had time to react yet. So the bicarbonate level will be pretty much normal, or maybe just slightly lower, but the pH will be quite high because there's no compensation.
Okay.
But if the condition has been going on for days, maybe due to chronic lung disease or living at high altitude that's chronic epithelial-entrenched, the kidneys have had time to compensate. They've dumped bicarbonate. So you'll see a significantly lower bicarbonate level on the ABG. This helps buffer the pH change, so the pH might be closer to normal, maybe just slightly alkaline, even though the PCO2 is still low.
Ah, okay. So the bicarbonate tells you about the timing, the duration. Are there other lab clues?
Yeah, we might also check electrolytes and see low potassium or low ionized calcium, consistent with the effects we discussed. But the anion gap, another calculation from blood tests, is usually normal in simple respiratory alkalosis.
And getting that ABG sample, is there anything special about that?
Yes, it's important. It needs to be collected anaerobically, meaning no air bubbles get into the syringe because air has a different CO2 level and can mess up the reading. And it needs to be analyzed quickly, usually within 15 or 20 minutes, or kept on ice if there's a delay.
Right, accuracy is key. Now, I've also heard about capnography, monitoring CO2 in exhaled breath. How does that fit in?
Capnography is a great tool, especially for continuous monitoring, like in the operating room or intensive care. It measures the CO2 at the end of an exhaled breath, the end tidal CO2. It gives you a real-time trend.
So it's not exactly the same as the arterial PCO2?
Not always, no. Especially in patients who are lying down or under anesthesia, the end tidal CO2 reading might be a bit lower than the actual arterial PCO2, maybe by 5, 10, even 15 millimiller Hg sometimes. This is often due to slight mismatches in ventilation and perfusion airflow and blood flow in the lungs. So it's really useful for watching trends, but the ABG is still the definitive diagnostic test.
Okay, that makes sense. So once you've diagnosed it using the ABG, maybe supported by capnography trends and the clinical picture, how do you treat it? How do you get someone back to balance?
The absolute number one rule, the core principle is treat the underlying cause.
Right, because the respiratory alkalosis is usually a symptom or a response to something else.
Exactly. We rarely need to directly treat the high pH itself unless it's extremely high, say pH over 7.6, or it's causing really severe symptoms like those seizures we mentioned. Otherwise, focus on the trigger.
So can you give some examples if the cause is low oxygen?
Right. If it's hypoxemia, you give supplemental oxygen. And you treat the underlying lung problem, maybe antibiotics for pneumonia or bronchodilators for asthma.
Okay, what if it's pain or anxiety?
Then you manage the pain with analgesics. For anxiety or fear, especially severe cases like panic attacks, sometimes short-term anxiolytics like benzodiazepines might be used. Relaxation techniques, reassurance, those are crucial too.
What about that paper bag thing you sometimes see in movies? Breathing into a paper bag.
Ah yes, the paper bag. The idea is to rebreathe your exhaled CO2 to raise your PCO2 levels. But honestly, it's pretty controversial and generally not recommended anymore, especially outside a hospital.
Why is that?
Well, there's a risk. If the person is hyperventilating because of hypoxia, low oxygen, making them rebreathe, CO2 could lower their oxygen levels even further, which is dangerous. Or you could overshoot and make them retain too much CO2. So it's generally best avoided unless under strict medical supervision.
Good to know. Okay, what about other causes like fever or sepsis?
Treat the fever with antipyretics, treat the sepsis with antibiotics and fluids. If it's a CNS issue, address the specific brain problem. If it's aspirin toxicity, manage that poisoning.
And if it's the ventilator causing it?
Simple, adjust the ventilator settings. Reduce the respiratory rate or the tidal volume, the amount of air per breath.
So it really always comes back to fixing the primary problem.
Always. And while you're doing that, you provide supportive care. Monitor and replace electrolytes like potassium and calcium if they're significantly low and causing symptoms. Ensure good fluid balance.
It sounds like our kidneys are kind of the unsung heroes here, working behind the scenes to correct the pH.
They absolutely are, especially in chronic situations. They do the slow, steady work of compensation. Direct interventions to lower the pH are very rare, maybe controlled rebreathing of a specific CO2 mixture in an ICU, or slightly sedating an anxious patient, or adjusting ventilation. But you always have to be careful.
Careful about what?
Well, you don't want to oversedate someone if the hyperventilation isn't just anxiety. Maybe it's compensating for something else. And you always need to consider if there might be a mixed disorder. Like someone with sepsis could be hyperventilating from the inflammation, causing respiratory alkalosis, but also developing lactic acidosis from poor tissue perfusion. It can get complicated.
Right, it's a puzzle. Okay, so after identifying the cause, starting treatment, what's the general outlook? What's the prognosis for someone with respiratory alkalosis?
Generally speaking, the prognosis is quite good, provided the underlying cause is identified and can be treated effectively.
So it really hinges on the cause.
Absolutely. If it's something transient, like a panic attack or mild pain that gets treated, the prognosis is excellent. It resolves quickly.
That's reassuring.
Yeah. But if the underlying cause is more serious or chronic, say, severe advanced lung disease or end-stage liver failure or a significant brain injury, then the prognosis is much more variable. It really depends on the outlook for that primary condition.
But the alkalosis itself, the direct complications like seizures or arrhythmias, are those common?
Thankfully, severe complications directly from the alkalosis are rare, especially if it's managed appropriately by addressing the root cause. The body, particularly the respiratory system, is incredibly quick at correcting that PCO2 level once the stimulus is removed.
It really is amazing. This whole deep dive, it feels like understanding something this specific, this chemical imbalance, it just highlights that incredible, intricate balancing act our bodies are doing constantly, every second.
It really does. And connecting it back, the remarkable thing is that speed of correction. Once you fix the underlying issue, The PCO2 often normalizes very quickly. It just shows the adaptability, the resilience of our physiology, always pushing back towards that equilibrium.
So maybe the next time you feel your breathing pick up, whether it's from stress or exertion, just take a second. Consider that subtle but really powerful chemical cascade happening inside you. What does learning about respiratory alkalosis tell you about the incredible, often hidden intelligence working within your own body?